So she's trying to claim it.
All right, so myasthenia gravis. All right, so myasthenia means weak muscles, right? Maya meaning muscle, thenia meaning weak, right? Gravis meaning grave or slow, right? Or a significant amount, I should say. All right, so it's grave skeletal muscle weakness. So it doesn't affect smooth muscle, does not affect cardiac muscle. It's only skeletal muscle, right? So it onsets like in the early 20s to 30s, and it also onsets in older age as well. And this causes fatigue, right? So use the normal neuromuscular junction here. Normally, we send the signal down from the brain, right? Via our, our pre-essential gyrus, it goes down, it goes to the thalamus, it decussates across, it comes across, goes to the skeletal muscle, right? And as it makes its way all the way down there, it's going to release what neurotransmitter? In neuromuscular junctions, what neurotransmitter is it? Acetylcholine, right? So acetylcholine will then bind to the next, go across that little cleft and bind to an acetylcholine receptor, right? And that will then potentiate that muscle action potential across, and the muscle contracts. In myasthenia gravis, that process is disrupted. So we have little antibodies that attack the receptors, right? Or we have antibodies that attack the building blocks of the receptors, right? Tyrosine kinase machinery. All right, so 80% are due to this process where we have basically have a recent infection, and that infection, we attack the infection, right? So we form the antibodies against that infection. So here's the infection. Our little white blood cells will say, hey, I know I'm going to make antibodies against that, right? And I'm going to make T cells to also attack that specific antigen, right, of this foreign invader, right? So then that invader is destroyed, but also that invader's license plate or antigen looks exactly like the neuromuscular junction, so or the building blocks of it. So it goes and it starts attacking one of the two, either the tyrosine kinase inside or the actual acetylcholine receptor sites, right? It binds to them and it sticks to them. It doesn't actually stimulate the muscle. It actually just binds to it and stops it from working. All right, so now the muscle doesn't work good, right? So because of our acetylcholine receptor sites are destroyed or are not being produced. So that's the idea behind myasthenia gravis. Is you have some kind of stimulating factor, usually a recent infection of some sort. It can also be due to a thymoma. Where's your thymus gland at? Behind is your mediastinum. Where's your mediastinum at? Right, it's what your heart sits in, and when your thymus sits in, right? So it's just below your thyroid gland and above your heart. But that thymus is where T cells go to university. It's like an ABC of the immune system. It goes there and it learns about different immune processes. And it learns the wrong information, unfortunately, and it goes out and starts attacking these receptor sites until it is ineffective, right? And so we have decreased acetylcholine receptor site activity, or decreased amount of receptors, and therefore we can only do so much activity during the day. So we get what's called fatigability. We get very, very fatigued. We wake up in the morning, we're energized, and by noon or 2 o'clock, like right now, we are fatigued, right? It's not because we all have myasthenia gravis, there's other reasons why too. Oops, sorry. So different types of myasthenia gravis. So we have ocular bulbar, and we've talked about this before, right? So we're going to copy and paste what we know about cranial nerves to right here. So our cranial nerves, they leave the brainstem right here, right? Whether it be the medulla or the pons or the midbrain, they leave that and they then innervate. They then arrive at a muscle, right? And at the muscle, it releases acetylcholine and it makes that muscle work. One of those, let's say cranial nerve 3. Cranial nerve 3 is your oculomotor nerve, 3, 4, and 6 technically. It goes to the eye muscles and it makes the eye muscle move, right? So if you're reading your textbook all night, right, you're reading, you're going to get, your eyes are going to get exhausted from moving all the time, right? That's going to cause, fatigability of your eyes, and therefore your eyes cannot, they cannot operate correctly, so you get diplopia, right? Your eyes start getting double vision over time. That's with cranial 3, 4, and 6. And then what is the strongest muscle in the body? Tongue? No. Huh? Masseter? It's the second place. Masseter is second place. First place for us guys is the uterus. All right, uterus is the strongest muscle in the body. And I guess you could get fatigability of that, but it's really a smooth muscle. But the second place is the masseter, so chewing, right? So they have unfinished meals because they got fatigued. They couldn't finish their meals, right? And then we have, third place is, we got our what is it? Our eyes. Our third place for the muscles used the most throughout the day. And then our legs, our arms, to get fatigability is the idea, right? And then cranial nerve 7 innervates our face, right? So cranial nerve 7 comes to our face and it tells our face to do things, right? To contract and have expression and have and maintain its shape. But what if it fails? Then you get ptosis with a silent P. So you get this eye droopage, right? So the eyelid droops across the pupil, and that's called ptosis. Right, and then cranial 9 and 10 for gag and swallowing, and it's also 9 and 10 are also used for orthostasis, right? That's what receives the signal from our aortic arch and from our carotid bodies. It goes to the brain and tells the brain what's up. It says, hey, the blood pressure is low out here. Go ahead and fix the blood pressure. But if cranial 9 and 10 don't work, you're not going to get that response. Okay. And then cranial 11 is your spinal accessory muscle. That's what our nerve. That's what controls your head movement, right? Going left and right and down, forward and back. So that's going to be weak. So you can easily push someone's head back. Okay. And they have this nasal type of voice. They have this trouble swallowing, trouble articulating things, and that's a symptom of myasthenia gravis, right? So all we do is there's no new information here. It's all ocular bulbar. They get ocular bulbar weakness. And the other unique thing about it, besides all those other fancy things, is they get fatigability. So fatigability and ocular bulbar symptoms, right? So the same thing. They got ptosis. We have trouble swallowing, like gag reflexes impaired. So that means we have risk for aspiration. We have risk for falls because of the orthostasis. We have dysphonia. They got a nasally voice. Dysarthria. They don't articulate that well. So that's the signs of someone with myasthenia gravis. Okay, so the most common reason they seek care is because of that fatigability. They can't go throughout the day finishing dinner. They can't go throughout the day. They get weak by noon. That's usually why they seek out care. Okay, they can't do bathing or dressing. When it gets to nighttime before a shower, they don't have the energy to do that. All right, so the diagnostic tests you do are, they can run a serum test to see if you have those antibodies, if you have those antibodies against those neuromuscular junctions. Right? We used to do an edrophonium test that died in 2018, so that's 6 years ago. We don't do edrophonium tests anymore, but it was a cool test where you could give them a acetylcholinesterase inhibitor, and that would make more acetylcholine be around, and therefore they would get stronger. The ptosis would improve, right? So the ptosis in the top right there, you can see on the left here they have ptosis, and maybe they gave edrophonium or a tensilon test, and maybe it improved, right? Obviously, the side effects are sludge BB because you're going to have too much acetylcholine, right? You have salivation, lacrimation, urination, defecation, GI, and vomitation, right? And you're going to have BB. What's BB? That's bradycardia, not tachycardia, and broncho what? So that sounds like a really good SATA question, right? So like identify the following sludge BBs, okay? And then it's for a medication, right? And that medication could be anticholinergic or cholinergic. So one is can't see, can't spit. One is, sludge BB. And then someone might have been a nurse, I don't know, but they said you don't need a tensilon test. All you need is an ice pack. Hold my Purewick. I don't know. Hold my beer. You're not gonna have a beer at work. But anyways, they went and grabbed an ice pack and they put it over the eyes, and the eyes got better. Right, because neuromuscular junctions work great when you have coldness, or they actually work better. So instead of trying to induce a medication, give a medication IV and causing bradycardia and bronchoconstriction, all you gotta get is an ice pack and slap it on there and say, hey, look, it improved. You have Guillain-Barre. Okay, so every time you're tired, you grab an ice pack. It's like, oh, good, no Guillain-Barre today. Okay, they could do a CT of the thymus if they worried about the thymus being the reason for it. They can do a electromyography, where they look to see if the muscle's impulse is being conducted efficiently through from the wrist for right here into the hand. and they can measure the impulses to see if they are lower. That means that the muscle is not getting those impulses as well as it could. Okay, so they get fatigability throughout the day. They got ptosis. We gave an ice pack. Ptosis improved. Okay, so cholinergic crisis. That's kind of rare. It's when they take too much of their medications for myasthenia gravis, and that's obvious. And the idea with the myasthenia gravis medications on the next slide are to potentiate acetylcholine. Right, that's the whole purpose of them. So if you took too much of them, obviously you're gonna get sludge BB. But the treatment for myasthenia gravis is to promote more acetylcholine to stay around, right? So we have acetylcholinesterase inhibitors, right? So pyridostigmine is PO, and we have an IV form that's called neostigmine. So these are our two go-to agents. They're going to be discharged on these medications. These medications are going to be there to make more acetylcholine available at the neuromuscular junction, right? They're going to go here, acetylcholine gets released, and acetylcholinesterase inhibitors are going to stop the breakdown of acetylcholine. They're going there and they're going to say, keep acetylcholine around for longer. That way they can then, do their action, right? Which is to do muscle contractions. So what else can we have? We have other agents out here that are basically going to stop the autoimmune process, because myasthenia gravis is not something you just go to the hospital and you're cured, right? Myasthenia gravis is a chronic disease that you can get a myasthenia crisis from, right? Just like for CHF, you get a CHF crisis or CHF exacerbation. When we talk about COPD and asthma, they have crises and exacerbations. Myasthenia has a crisis or exacerbation, right? And definitely during a crisis, we're going to give steroids to help stop the infiltration of B cells and T cells into this membrane here. All right, so they're going to stop that process. We have other medications here like calcineurin inhibitors. They're going to inhibit T cells. And T cells do what? Do they make antibodies or do they attack things? T cells are bounty hunters, right? They go out and attack things. They read the antigen and they say, okay, say no more. And they leave and they kill it, right? So they read the antigen as, neuromuscular junction or acetylcholine receptor, right? So we give this medication, this calcineurin inhibitor, to stop the T cells from being made, right? Corticosteroids stop, pretty much simmer down everything. We have MABs, right? Monoclonal antibodies are always designed to target something specific. And this one is designed to specifically target these acetylcholine receptors to stop them, kind of be a little bit protective. And then we have different chemotherapy drugs even that can be used to stop the production of B cells and T cells. All right, so a crisis. A crisis occurs when we forgot our medications. That could be one, right? Another crisis could be when they have an recent infection, because an infection is going to put a lot of more B cells and T cells out there, and that's going to potentiate myasthenia crisis, right? So it's life-threatening when they have myasthenia crisis. They may need to be intubated. So one of the key things here to take away is that, the end result is they could stop breathing as the diaphragm gets fatigued and it can no longer breathe, right? So we have to always assess this. Whenever you get a report on someone that has myasthenia gravis, you ask them, what is the vital capacity? Because the vital capacity tells you if they are needing intubation or not. If it's less than 1 liter, you're needing intubation. They need to go to the ICU and be put on a ventilator, right? But if it's more than that, we're going to keep doing these tests like every 12 hours or every day at least. Okay, so normal is at 60, 80 per kilo. So if someone weighs 100 kilos, that's how many liters should they be? 6 to 8 liters, right? Is how much they should have for vital capacity. And what is vital capacity? Vital capacity is how much air you can breathe. Not how much air you breathe with each breath, right? With each tide, inhale, exhale, that's tidal volume, right? But if you take a huge deep breath in all the way to your ultimate capacity, and you exhale to your ultimate capacity, that is your vital capacity, your capacity to live, I guess, right? So vital capacity is, they take a deep breath in and exhale, and they blow into a little spirometer, and it measures their vital capacity, okay? And then NIF, or negative inspiratory force, right? When you inhale, that's a negative force, right? You can measure that. They can put a little device there and measure how much inspiratory force they are pulling, right? Like an instead of spirometer, they're inhaling, right? And with someone with myasthenia, they might not be able to contract that diaphragm, which is part of inhalation. Okay, so that's a key takeaway for myasthenia crisis and for Guillain-Barre. IVIG is given for myasthenia gravis, it's given for Guillain-Barre, it's given for multiple sclerosis. It's basically a, I don't even know what this maneuver is called, where we're just deploying all the flares to block everything, right? So it's basically a flare tactic where if you have like a homing beacon, this little myasthenia gravis attacking antibody that your body made, you give IVIG and it's going to attack that instead, right? Also, IVIG kind of confuses the whole immune system and it stops a lot of processes, a lot of immune processes from taking hold. And the last thing is plasmapheresis, which is used for Guillain-Barre and multiple sclerosis as well. Plasmapheresis is like dialysis, so you have to hook them up with a vas cath, and they're going to take all the blood out of their body, and they're not going to return the plasma. They take all the plasma out, and that's where antibodies sit, right? Antibodies sit in the plasma, so we're going to take all that plasma out, we're going to pherese it, take all the plasma out and replace it with albumin. So you're taking all of the antibodies away, basically, with plasmapheresis. It usually requires about 5 days or 5 sessions or so, usually 1 session per day, and they take all that stuff out. If you're taking someone's blood out, you have to anticoagulate it. They anticoagulate with citrate. So if you anticoagulate with citrate, you have a risk of hypocalcemia and bleeding because citrate binds calcium. Calcium is used in our clotting cascade, right? So those are the 2 big risks. And as we'll learn with dialysis, the other risk for dialysis and plasmapheresis is low blood pressure. Okay, so certain medications do not do well with myasthenia gravis, and those medications are ones that would block acetylcholine, right? We want to potentiate acetylcholine with myasthenia gravis. So if we have these guys down here, anticholinergics, we have medications like calcium channel blockers. They're going to block calcium channels. Right? One of the side effects of calcium channel blockers was fatigue, right, and weakness. So that's probably not great for someone with myasthenia gravis. All right, so Guillain-Barre. So in myasthenia, we were affecting the neuromuscular junction, right? In Guillain-Barre, we're affecting the peripheral nerve that's going to that junction, right? So this was the muscle right here, right? And we have the CNS here, and we have the PNS here, right? We're going to be attacking this area right here, this myelin sheaths in the peripheral nervous system, okay? So this is a peripheral nervous system disorder. Was myasthenia peripheral nervous system or central nervous system? What is it? Myasthenia was where are skeletal muscles? Are they inside your brain and spinal cord? The other peripheral nervous system, right? So Guillain-Barre, not Guillain-Barre, but Guillain-Barre is it has a new name for autoimmune demyelinating polyneuropathy. Cool, but Guillain-Barre is much more fun to say. All right. So the nice thing about Guillain-Barre is it's not a chronic illness that you're going to live with for forever, like myasthenia would, or Parkinson's, or Alzheimer's, or strokes, or ALS, or the other neuro diseases. It's something you can recover. It's 85% of the time you just have very spontaneous recovery, right? But the mortality is extremely high. It's higher than a lot of other diseases, acutely at least. Right? So what else? So the cause is not entirely known, but it's like myasthenia. It's usually due to a recent infection. Right? A GI infection. Campylobacter is an important one. They have pneumonia. They have CMV, cytomegalovirus infection, Zika virus, Epstein-Barr virus. You'll find Epstein-Barr everywhere. Epstein-Barr virus is almost every single disease process is caused by Epstein-Barr. But a recent viral infection, recent bacterial infection can cause Guillain-Barre. All right, so Guillain-Barre is going to cause a lack of those. It's going to cause a breakdown. It's also an auto antibody situation. You form the antibody to attack the Campylobacter or to attack the CMV, but you also that it looks just like a Schwann cell, right? Where are Schwann cells located? They are located around neurons, right? Specifically peripheral nervous system, right? So in the peripheral nervous system, it looks just like it. So you form antibodies against the Campylobacter, and then usually like 1 to 3 weeks later, those antibodies start breaking down the peripheral nervous system nerves, right? It's called molecular mimicry. It just looks just like it. It's like, hey, you look like the same person in the dark. It's like, no, that's not me, right? So then it starts causing problems. So the PNS, and again, you have to say that slowly, otherwise it sounds like something else. All right, so the PNS, whereas that has motor nerves, it has sensory nerves, and it also has the autonomic nervous system, right? So those are where all of our symptoms can be. We can have, most commonly it's motor, right? Where our motor nerves is going to lead to weakness, or is it what's going to lead to? It's going to lead to lack of peripheral nerves from working on the motor system, so we cannot contract good, right? And the unique thing about this is it actually starts in the toes and then up it goes. It's an ascending paralysis. So it starts down here and then it goes all the way up, right? And it's a peripheral nervous system disorder. We're breaking down the wrapping of our nerves out in the periphery, okay? So they stop working, and then we also lose reflexes as well, because motor reflexes, it requires a motor neuron, right, out in the periphery. So we lose reflexes. That's one of the key things that kind of differentiates it from other diseases. All right, so our symptoms, so areflexia. And look, there it is again, oculobulbar, right? Because the nerves have to leave the CNS, right? They started the brainstem, or they started the pons or medulla, they left it, and then they then deposited it onto a muscle of some sort, right? But along the way, they were wrapped with Schwann cells, which got destroyed. And that destruction is what then led to the weakness of that nerve, right? So it could be our cranial nerves. So we have oculobulbar paralysis or weakness. So it's going to cause a lack of what? So 3, 4, and 6 are diplopia, extraocular eye movement. We're not able to move our eyes good. And then we have what else? Just going down the list, they have swallowing difficulties. They're going to have an aspiration risk. They're going to have and not only an aspiration risk, but they cannot deal with their secretions at all. Like someone with myasthenia gravis can actually manage secretions just weakly. These guys develop paralysis, right? You can rebuild your Schwann cells, which is nice. You can't rebuild neurons, but you can rebuild Schwann cells. So that's the kind of the recovery piece. You can develop autonomic problems. So that was the motor problems, right? Autonomic problems would be your SNS and PNS. They can go back and forth. You can get rapid bradycardia, You can get severe bradycardia or rapid heart rates. You get a hypotension or hypertension, and that's really the most deadliest piece of Guillain-Barre. Okay, and then sensory-wise, you can get pain associated with this as well. It's not as common, but it can happen. And the diagnostic tests, how do we know someone has Guillain-Barre? We can do an LP, and it'll have the proteins spilling into the CSF. We can do a conduction of the nerves and see that the conduction is poor, because what nerve wrappings do, or Schwann cells do, is they make it so that it's easier to conduct electricity, right? Or faster even. So you're going to find that it's reduced when you do this test. So the goal is to reduce symptoms and avoid intubation. It's the same criteria for myasthenia gravis that it is for Guillain-Barre. We're going to make sure they have a good vital capacity, make sure they have also they have a good NIF, right? So a NIF that's good, and the vital capacity is good, right? So if it's less than 20 per kilo or less than a liter, they need to be put on a ventilator, okay? Also, remember, they can't handle the secretions. So how many secretions do you make every day in your mouth? How much do you make? How much is a lot? 5? 30? This right here is what? This is 33 fluid ounces, right? 30 mLs per ounce. So how much is this? Like 1.1 liter? Do you make more than this? Just on your own, just sitting there, how much are you making per day? It's about 2 liters. 2 liters per day, right? So you make about 2 liters of fluid per day, and you have to deal with that. So that can make its way to the back of the throat, and then you can aspirate, right? So it's important that we manage the secretions. And somebody say, oh, just put them on a BiPAP mask, which is going to blow the fluid back into their lungs, okay? The treatment is very similar. We don't give steroids for this one, but we do give IVIG, and plasmapheresis. It's the same, just copy and paste, same stuff, same complications, same risk, same efficacy, same effect, right? We are going to stop those antibodies from attacking our what? Our Schwann cells, right? Schwann. All right, so the complications. Death is a complication. It's like the least, what's the word? It's not as long-lasting as other ones. Like you don't usually have long-lasting effects or deficits from this disease, but you can die from it, which is, I guess, long-lasting too. All right, so then autonomic dysregulation, that is the deadliest one. That's where your heart rate goes up and down. All of a sudden, your blood pressure goes up to 220, and you get a hemorrhagic stroke, right? And game over. All right, respiratory failure is a significant reason. That's why we monitor our significant side effect. That's why we monitor our PFTs, or pulmonary function tests, for these. And then immobility consequences. You don't have deficits from it, but it might take you 3 to 6 months to recover. All right, so it takes a while to recover from this disease process. Okay, just a word about NIF. All right, so it's greater than -20, not less than -20, because less than -20 is a positive number. Right, that's how math works, right? If I have greater than -20, if I have a greater debt, right? If I have -$20 in my bank account, and then I have greater than -20, that means I have like -40, -60, -80, right? So if there's less than that, that's going to be an improvement.